Welcome to On the Pulse, our new podcast hosted by Hoop Nursing, part of the Hoop Recruitment family. We'll be hosting a series of 8 episodes, each looking at different perspectives within healthcare, hearing directly from health professionals working in the field. For our second episode, I am delighted to be joined by Jenny Williams, a registered mental health nurse who qualified in 2011 and gained her PGCE in 2018, enabling herself to educate health professionals in the healthcare sector also. Jenny is a working mum and manages to balance 12-hour shifts in mental health hospitals alongside providing tailored training to the healthcare sector, all whilst raising a small human. No small fate.
Thank you for such a lovely introduction.
Well, I think it's absolutely just. So hi Jenny, thank you so much for meeting with me today. I think it's really, really fundamental to me with regards to when I met you for the first time, it's really clear your passion for mental health nursing. And for me, it was, I attended one of your courses, and I think from that actually provoked, as I said to you just prior to switching this on, provoked the podcast and actually looking at exploring your experience and other people's experiences within that room of healthcare professionals. It was really beneficial to me. So that's hence we've created this. So thank you for that in itself. But I'd like just to start really, for those who are listening, just if you could introduce yourself, a bit about what you do in terms of your work, both as a trainer, but also more of the mental health nurse element, if that's okay.
Yeah, absolutely. I'm really glad to hear that you enjoyed that training. That's what I do it for, is to make sure that it's meaningful. It's not just tick boxing to get a certificate. So that's really lovely. About me, I qualified as a mental health nurse in 2011. Got my dream job working in CAMS in the NHS with teenagers, 13 to 18 years old, with severe and enduring mental illness. I did that for a year and really, really enjoyed it, had loads of positive experiences and really embedded all of my training and found my feet as a nurse. And what I found from working in the NHS was the rotation of shifts was really difficult. So rotating onto days and nights and the constant chopping and changing in between, and the impact
takes
that
its
was
toll, doesn't it?
Absolutely. The impact that was having on my personal life was massive.
So actually, with CAMS then, because I know obviously you've gone, I say obviously as if everyone else should know this, but I know that you've gone into different areas as well as CAMS. But if we touch on that one, I mean, I think that's really interesting for myself, and I'm not a mental health nurse, I'm a general nurse. But for me, I think that role of a mental health nurse with that population of clients that need care, I just think is so fundamental to the future of this country. So for me, I suppose I've never done a shift there. So for me, I suppose I'd like to explore that a bit more. So could you, I suppose, start by maybe we could look at that and then we can come back then to other experiences you've had. But if we could look at what would a typical shift look like for you? So, think into when you actually arrive and then the handover, what does that handover look like? What does your first, just to give context, so for nursing homes, obviously you go to the most critically unwell person first, those things, or you go and assess everybody and then you start your medication. It's quite, within private sector, rather than the NHS perhaps, it's a bit more conveyor belt, which I don't like that term, but that's the reality, I think, sometimes, that there are expected tasks at certain times. So for me, I think it's learning about, is that the same in that experience you had in the CAMS service?
Yeah, it's an interesting question actually, because the main difference between the NHS and private healthcare, I think the conveyor belt that you're referring to, is that often the pressures on the NHS, particularly over the weekend, are absolutely huge. So you end up with patients going into private healthcare over the weekend where they have a surge and struggle to manage their caseloads, and then there's a higher chance in private healthcare that come Monday morning a bed will free up in the NHS and they'll be moved back to the NHS. Right. So you see a greater turnover of patients in private healthcare than what you do in the NHS, where they will come in, get the full service that they need and then go. So it's a little bit more turbulent in private healthcare.
So with that then, sorry Jen, I've got so many questions, honestly. I'm gonna be a nightmare, honestly. But so with the patients, because again, that's something I didn't really think about. Unless you're in that field, I suppose you wouldn't think that they dip toes into both, and so how long is, and I know, sorry, we are going to go back to the shift question, I promise, but how long then and I know this is a piece of string question here, but how long would a patient, a teenager, be in the NHS then, rather than private health, if that makes sense? So how long would they be with you then?
Yes, so this is the difference perhaps between our nursing disciplines, because you're an RGN and me being a mental health nurse.
Yeah.
Recovery is very, very different.
Yeah.
So it's more measurable, I think, in your discipline, because someone has broken leg, for instance, that
We can
you
see
put
our
a cast
issue, can't
on
we?
it, you can take a picture of it, put a cast on it, and know that, in 6 to 8 weeks that's going to be healed and recovered. Recovery in mental health is very different. Our patients are on a journey, and we have to be led by their risks, and we have to move with them at their pace. So we have a lot less kind of control over how long things are going to take. And so we have to be led by the presentation and the risks of that person, and do what is absolutely best for them. And there are so many variables in that. And again, with your question of them moving around and chopping and changing from private to NHS, geography is a huge variable as well. So sometimes there won't be beds, especially in CAMS. There will be a struggle nationally to find a bed for someone who's in dire need of one. So sometimes that young person will be moved hours away from their loved ones and from their home. And so of course then there's pressure to get that young person a local bed as soon as possible. One, financially, because it costs the NHS more to transport them, and it costs more to keep them out of area for each of the local trusts. And secondly, of course, for patient-centred care, they need to be in their area and
Absolutely
closer to their loved ones, so that they can have visitors and whatnot. So yeah, there's lots of variables really.
Yeah. Okay, sorry, I totally digressed. I am the queen of digression. I think that is something I really have learnt. So sorry, to go back then to your shift. So yeah, in essence, if you could just kind of talk us through a CAMS shift, I think that'd be really interesting. And I promise I will stop talking.
That's absolutely fine. So a typical shift, for an early shift, I'd arrive at 7 a.m. Night staff are still there until 7:30, so it allows that half-hour handover period. So we would all sit down in a room together with the nurse in charge from the night shift, and as the entire team of the day shift coming on, and we'd understand the last kind of 24 hours, maybe 48, anything significant for each patient. So typically we'd have about 12 young people in our care, and there'd be about...
Is that for you and your team? So
yes, that would then be...
I was going to say otherwise, wow.
Yeah.
But even so, I mean, that's still, isn't it? Because how many staff then would that roughly be?
So that would be 2 nurses and 3 healthcare assistants, assuming that you were fully staffed.
Assuming, yeah.
And then there's different levels of observation for each patient, so we need to know where they are and what they're up to, and their risks will dictate how often we check in on them. So at one end of the scale we will check hourly as standard, just to make sure that they're here, they're in the building, they're okay. That would be for someone who's got a lower level of risk. And then we go up the scale, so they might be on 15 minutes or 5-minute levels of observation.
Wow.
Or if they're really, really unwell, then they may need one-to-one support, so someone will be with them within eyesight at all times, sometimes even if they're using the bathroom.
So could you get another member of staff in to facilitate that? That would be surplus to that core team you've got?
Yeah, that's it. And then depending on the levels of their risks, that can increase also to 2-to-1, 3-to-1, because you've got to think if they're aggressive to others, then we have to manage those risks to other young people and to ourselves as staff members as well. So our base numbers would be 2 nurses to 3 healthcare assistants, and then that rises depending on how many how many people on what we call enhanced observations there are.
Okay.
So from there we get a full handover. We go through each patient, understand any recent changes in their risks. Anyone who doesn't know the patients well, the handover will go into more depth as to what they're doing here and a little bit more about the basics of their care plan. And from there, as nurse in charge, then I will allocate jobs that need doing immediately for these patients. So it might be that someone needs to go around and wake them up. It might be that we need to allocate people to go on to their enhanced observations, or it might be that I need someone to do their 15-minute observations. So I'll allocate out all those jobs straight away and just make a note of who I've allocated to what. And then I'll go into the office, and generally there's a big whiteboard where we will allocate jobs for the entire shift. So the team will know exactly what they're doing. I can speak to the team and understand if they've got when they'd like their breaks, and if I don't know the team well as an agency nurse, I'll be making small talk when we're waiting for handover and trying to suss out who's experienced, who's got the skill set, who knows the patients, who's new to the place, so that none of my allocations as a nurse in charge are done randomly. Everything's done for good reason and trying to make the most of the skill set of the staff and to make sure that everybody's happy and confident and competent in what they're doing as well.
So with that then, Jen, just to pick up on, you said you go and wake them up, because of the patient. Is it patients? It's such a, even the word, isn't it? Because people call, in healthcare, you can have service users, clients, patients, residents, because they're teenagers. I suppose I'm this, as a mother, I suppose CAMS in particular, I get, I think it's quite cold. Certain words I find quite cold. I don't like service users, if I'm honest.
No.
And I know that I had to mandate that term before. I just don't like it. It's so transactional. We're dealing with human beings, So what would you call your patient group? They're patients, because the NHS, and it's, I suppose, short-term care, isn't it? Rather than, they're not long-dwelling placements.
Well, they can be. But yeah, you're right. The CQC would like us to call them service users.
I really don't like it.
In all of my years, when I've had conversations with people about what they want to be called, they're more than happy with patient. That's what feels congruent to me.
Agree.
And also the boundaries as well, because in mental health often we don't wear uniforms because we don't want this sort of power dynamic. We don't want this us and them culture creeping in. And so for young people in particular, that can start to get a bit confusing. They can forget where they are, and that's not helpful when they've got an eating disorder, for instance, that's screaming at them that they're fine, they don't need to be there. So I think that language of, nurse and patient is helpful for that.
I think it's something that I don't think you can reinvent the wheel.
No.
Because I think it's very much, it is that, isn't it? Don't get me wrong. I think, where I come from, nursing homes is my passion. That's where, my love lies. But they weren't my patients, they were my residents, because I was in their home, and it's different. But the NHS, when I was a student nurse in the NHS, people were patients. I think service users, I just don't like it, if I'm honest. I think it's really derogatory as well to everybody involved in that. I just think it's what's happened, and I'm going to speak out of turn here, is that a box is being ticked, and but patients, they in NHS, if they are coming through that process, I think, as you say, it's the boundaries, especially, and this is me just looking in, again, with a very, very inexperienced mental health eye, but it would be very much that if, they understand, okay, that's the nurse. There is expectation. They will have preconceived ideas throughout their childhood of what a nurse does.
Yeah. Nurses
are there to help you. I'd like to think, apart from the present day, that nurses are painted in a lovely light, as children, when you've got children doing role play as nurses and things, it's a lovely, warm little buzz you get, when my daughter, but it's, the reality is, that should be their expectation of somebody. So I can, sorry, again, digression.
No,
I think it's a good point in terms of they are your patients, because, and you're their nurse, and you're the one that they're going to look to for safety. for reassurance, for guidance, and their families will as well. And I think it's the patient's relatives, isn't it? You know, so anyway, sorry.
Yeah.
I've gone off on one.
No, I completely agree.
So, yeah, I just think it's an important topic, isn't it? You know, that in itself, I think, it's just important for that word boundaries you use, especially with that patient group, is so fundamental to their I suppose their recovery, isn't it?
Yeah,
and it's the different words, you know. I noticed that when you were talking about it with, you know, the comparison of an RGN like myself. I worked with adults that had degenerative neurological conditions, so actually for them, I had to move the care with them, but it was more of the physical aids and obviously the social well-being and making sure that they you know, their well-being in general, holistically, was cared for. But I think it was more of my primary focus, probably, was making sure they were safe and as comfortable as they could be, if that makes sense.
Yeah.
And I don't know if that's the wrong thing to say, but for me, their comfort and their making sure they weren't anxious and making sure they were comfortable was my fundamental reason for being there, you know. So I think there's different areas of general nursing, but I think for mental health there's so many different areas here, and our terminology is different as well, isn't it? And that's why it's just funny to have that conversation, and just sat here now for 5 minutes, I just find this so fascinating, the world that you're in versus you know, any other world that I've been in, for example, and this is why for me, having you here, you in particular, with your experience, I'm just honestly so grateful. So anyway, again, I've gone on.
I think it really crosses over though as well, because I remember we were lucky to have a paediatric nurse as part of our team, and she would then help us with anything physical that was going on with these young people, because there are overlaps.
Absolutely, there's so many crossovers, you know. It's, you know, I remember in my training, and I qualified 2009, so similar time, and it was, you know, you've got your paths to choose, but actually I was dealing with emotional well-being and some mental health, anxiety and depression. We're giving out medication for those things as general nurses, you know, but yet actually we should probably cross over a bit more, because there are so many laps, aren't there, and overlaps. And I think you're right, it's paediatrics, you know, they're going to, people, I mean, again, this is me being very assumptive, but I assume that you've got people with eating disorders on pegs, you know, requiring peg feeding and you know, other nasogastric tubes, whatever they're going to need, you know. So there's lots of, as you say, crossovers. So anyway, I'm sorry. Oh God, we can go on for hours here. Honestly, we really can.
That's
me and you chatting, it is a good thing. But honestly, but it's just so interesting. So can I ask then, on your shift then, so you've delegated and, you know, following up and, you know, making sure that everyone is as safe and as, you know, according to the care that they require that shift and on track.
Yeah, that's the first major thing.
Okay.
Is plan the day and really get the reins on the shift.
Yes.
You know, and you might be dealing with shortages in staff, and you've got young people on enhanced observations and young people that are anxious about their day and they want to talk to you and the phone's ringing, and so I make it sound like, yeah, you just go in and you plan your day on the board.
No, that's the ideology of what it, no, I absolutely get that, because it's the ideology. That's what it does on paper, but the reality is a different kettle of fish. No, and this is what I suppose, that's where I want to kind of get to, but actually that's really important we understand what it's supposed to look like.
Yeah.
Because for all the will in the world planning, you know, and it is, you need to get control, because the minute that's gone, I imagine, it's like on any shift, isn't it? It's, and you've got, as a nurse, you've got to keep calm. So you have to, you know, even though it's like that duck, isn't it, the metaphor they use, and your legs are going like the clappers underneath the water, but no one else sees it.
Yeah.
We're all in control.
Yeah, that's
anyway,
right.
So,
That's right.
So if we go
But
back then.
That's my opportunity then to like, right, breathe.
Take a minute,
That's done. Coffee. Go out and say hello to everyone. Go and do a little head count. Make sure everyone is where I heard they were. just make sure that we're
Sanity
settling
checks.
in okay.
Absolutely.
Yeah, definitely.
So with your shift then, if so things, say, you know, you could be, you know, things are going as planned, what kind of things then would crop up in your shift?
So talking about a CAMS setting, there's such a wide range of mental illnesses and conditions and symptoms that we're dealing with. So commonly about a third or half maybe of our patients will have eating disorders.
Right.
And so that comes with a very rigid timetable around not only the meals but the aftermath of those meals and how we support them afterwards and make sure that they're not engaging in any compensatory behaviours, exercising, trying to make themselves sick or anything like that to compensate for the calories that they've just consumed. It brings up a lot of feelings for them.
It's so sad, you know. I just think to have the children, aren't they, as well?
Yeah.
I think
absolutely.
you're amazing, all of you. So anyone who works in camps, I just think you're incredible. Anyway, sorry.
So we have this whole eating disorder program going on for a chunk of our patients, and then for our others, they might be depressed, they may be psychotic, they may have a lot of anxiety. There may be some autistic traits that we're trying to assess and understand what's happening, and these all behave in and manifest in very different ways. And so it's trying to make sure that you're providing care equally and giving everybody what they need, because it's really easy for someone who's really floridly psychotic to take a lot of time and attention from the team, because their needs are so obvious, whereas you've got someone with depression who's sat in the corner, who's perhaps out of eyesight, and you don't know whether they're safe and what they're doing. So it's incredibly easy to overlook the quiet ones who are potentially posing the most risk to themselves on that moment. Yeah. So it's a real skill to make sure that everyone is getting what they need. And
you've got to have eyes everywhere, don't you?
Yeah.
And I imagine that team is absolutely crucial to you.
Well, yeah, because it's down to the experience of the team, because it's very easy if there's an incident, particularly if it's a challenging incident, alarms will sound, and we're trained to, of course, respond to those alarms and make sure that the person's safe and that the colleagues are safe. So it's very easy for everyone on shift to flock to attend that alarm, and then of course other young people can have feelings and worries and concerns around that. They can then feel less contained because they can see that all of the attention has gone on to one person. So if they were having thoughts or intentions to harm themselves, then that hands them an opportunity.
Almost like a trigger point then,
literally.
Is it?
So it's so easy again for those people to sink into the background and not get the care and support that they need at that time.
So just, as I said to you at the start of this, I knew questions would just start flowing in my head, and they really are. So again, when you have the emergency call bell, I imagine is what you're referring to, the emergency alarm. So if you're on a shift, that gets hit, the alarm goes off, you've got obviously an incident that needs addressing urgently, and you need to go and attend that patient. What does that actually entail, and actually what does that, as you've touched on, the implications for the rest of that shift, but also for the rest of the people in that moment? How does that look, and how do you feel, I suppose, in that moment?
It's a real game changer, because it depends on the skill set of the team that I have on massively, because as a nurse in charge, I will go and deal with the most high risk things that are happening on the ward, of course. But I also need an eye on the peripheries, and I need to know whether the staff who are on the enhanced levels of observations, on the one-to-ones, on the two-to-ones, I need to make sure that they're not rushing to deal with the emergency, because I need to know that the other patients are being looked after at that time. So it's about, again, having an overview of everything while focusing in on the highest risk thing that's happening.
I think that's getting my pulse, honestly, and my blood pressure going up and high, climbing, just listening to that, because I'm trying to put myself in a position, and I think as anyone who's worked in the NHS and we all are touched in various areas, haven't we? And I mean, I've worked very, very briefly in it's actually a prison setting. So for me, I know because of the mental health requirements and nursing needs that are there, when that alarm goes, it almost takes me back, but I can almost see and feel, because we're as experienced as we are, and as you become in time, and with obviously things happening, you still have that anxiety of, I need to focus now to prioritise, but it's the adrenaline carries us through, I suppose, isn't it? And our adrenaline starts going, but you also want to protect that person and those people in your care, not just to make sure that you've still got a pin at by the end of the shift, but because fundamentally they're human beings, and it's so, you want them to be okay, isn't it? That's why we've gone into the profession.
Yeah, absolutely.
And it's that sincerity of, so following that, so any incident happened, and I know we've talked about that briefly, and again, I suppose I'm going off on another tangent here, but how does that affect you afterwards?
It has a massive effect on me. I think because of the competing priorities, I think it, even now with a lot more experience, it's still quite difficult because you're often under-resourced, and say you're managing the incident with reduced numbers of staff, which are reduced again by the fact that you need staff keeping an eye on the rest of the ward as well.
Yeah, of course.
And then, of course, the whole ward is heightened because the other patients are worried about someone that maybe their friends that's had an incident. It's setting off things for them as well, and so they may then have incidents off the back of that. And then, of course, I need to check in with my colleagues and make sure that they're okay. But there's limited opportunity to do that because we then have a wave of paperwork to fill out. But we don't all want to disappear into the office at a time when everybody needs our support. So we're kind of dragged in two directions then before we even get the opportunity to think about
process
debriefing.
Absolutely. Well, that's not even talking about how you're feeling, is it? Everything you've just said, from the question that how does that affect you, actually you haven't answered it because you've gone about everybody, but that is because I suppose that's why you're in the job you do, Jen, because you genuinely, and as I said, I get that from the first time I met you care about everyone else, don't you? And that's the thing, it's that age-old saying, is it the old oxygen mask, we tend to put ours on last, as much as we should put it on first, but it's, in the reality of life, you're in a shift, you can't do that, you have to, as you say, you have to do all of those other things before then, you can actually go, holy shit, that was upsetting. That was, that has affected me, and I know you will, resilience, and we'll go, we're going to talk about that in a later episode, but, it's all of those things, there's just expectations that we just have to get on with it.
Yeah.
And then, right, move on, we got to carry on, crack on. Whilst we do, and I appreciate that, and I am, my father's very much the generation, right, come on, crack on, and that's what has been instilled in me, there is still that element of, but you have to digest. Because you can't just sugarcoat all of this, that everything's fine and you're fine, when you've had to deal with something that's really traumatic. And I'm sure you've had, as I have, you have those times in your career, and it is horrible, is for want of a better word, because something really awful has happened to somebody. And as much as you may have known a patient for 5 minutes, but you still, they're humans. That's somebody's mother or father or son or sister or daughter or whatever, that's somebody's level, and even not somebody's level because they have active relatives around them, that's a human being, and that you've just seen something really awful happen to somebody who may have done something to themselves intentionally in your, in your line of work, and I can't even begin to imagine that. So I just think, honestly, this is really insightful, and the value of having you here today talking about all this, I think for anyone listening who is thinking about being, going into mental health work, whether that be, the private sector or the NHS, but CAMHS in particular, I think this is really insightful for how the shift is, the realities of it. Because to attract people to do a job and paint the lovely advert of, yes, this and this, but the reality is, and we'll talk about the reward, because I'm conscious that right now it's all about the challenges, but it is rewarding, and that's on the flip of it. So I know I'm going to kind of lead on to that in a minute, but honestly, that honesty from you is really, thank you, because I think it's really important. So on that note then, Jen, when we're talking about, that early experience, and actually the people that do say to us, well, have you done that? Did you do this? And with that, how important are those nurses around you so when you qualify and you go into these environments, as much as you've done this training, no training prepares you for the minute you become a band 5 staff nurse. It just doesn't, because you are anxious, you are scared, and that comes with time. That fear, there'll always be a tiny, tiny bit of it, I think, for any nurse, you know, and the ones that don't have any of that, I do think are the worrying, people, because I think then you think you know it all, but we can't, you know, but I think for those early doors, when you do, you know, you get what were epaulets back then, you know, and you put them on. I know it's different because you don't have the uniform in mental health, but it's that, oh my goodness me, okay, so I'm now responsible. How important in that setting of a CAMS environment there, CAMS unit, how important are those more experienced nurses?
They're essential. They are absolutely essential, and their approach is really important as well. It's so important that we have compassion for ourselves and that we have compassion for our colleagues as well, and that can go amiss really easily because you think, well, they're nurses, they're caring people, surely they're going to look after themselves and look after each other, but it doesn't always go like that because of the stressful environment that we're in. So yeah, it's absolutely essential that we have more experienced nurses to learn from, and that they help newly qualified nurses into the mindset of learning new things and seeing mistakes as the perfect opportunity to springboard into the way forward and learning, rather than us just beating them up.
Yeah, absolutely. I think that's so important, isn't it? And as you say, it's a highly, you know, regardless, it's highly emotive situations that we find ourselves in as nurses, you know, and I think that in those times, sometimes you can be maybe a bit shorter than you would have been if there wasn't a, you know, and you've got a junior member of staff and you're thinking, well, you know, again, you reflect afterwards, but in the moment, we need some urgency on this, and they have to learn, I suppose, through maybe those times when you are being short, but then I think it's all about the follow-up, isn't it?
Yes.
You have to explain to them and have to have humility to say, I'm really sorry. You know, I didn't mean to come across, and I'm sorry if you received me that way. It was just in that moment, I had to get my point across. We didn't have time, X, Y, and Z, you know. So I think it's probably the same very much, isn't it? And I think they're vital, aren't they? I think across whichever walk of life, within the nursing, huge world of nursing, you do find yourself, it's so important, no matter how long you've been a nurse, you know, because at the end of the day, I know, do you know what I hear quite often, and I say quite often, but, you know, throughout my career I've heard, I'm sure you have, the training's not the same as it was. That's a common one. And even now I look back and it's not the same as it was with me, and it's always going to keep evolving, you know, and so there'll always be discrepancies, you know, and, you know, if we look at some of the nurses that come from overseas, their training is far more thorough than ours. In a lot, you know, from, if you look at it on paper, they do a whole, you know, they do midwifery, they do general nursing, they do mental health. We have so many more nurses from overseas that are dual trained than we do in this country, you know, so that we train and educate here. So we need to learn from those nurses, don't we, you know, and learn, and it's all about, I just think, an open dialogue.
Yeah.
And putting down those barriers. I know we're all stressed, and especially in today's environment now where the NHS is in the media all the time and those things, you know. But I think it's really important, isn't it, that we're both saying the same thing. We both feel the same on that. I think I'm sure we're not alone in that.
No, and what I really like is that you clearly have that growth mindset as well. So it goes both ways with our students and our newly qualified nurses. We can learn from them just like they can learn from us. So I'm often asking them, you know, what are the main themes in their training, because the universities always have a few themes that they're really pushing because we've learnt some recent lessons and this is what's come out of them, and so it's really interesting to understand what's changing and understand the theorists that they're being encouraged to look to now and what's the new stuff coming out. They're at the cutting edge of it. They've got so much to give us.
And it's respecting that as well, isn't it? You know, they are the future, because there's going to be a day when this lot's retiring, we're retiring, you know, it's the circle of life, and we have to nurture them as well, don't we? And, you know, they're going to have those shifts that you had, that I've had, but I'd like to think that we've learned lessons, we've implemented things, and we've evolved, haven't we? But there'll always be those shifts, you know, that are going to be... and actually then, to go on to that, so I know we have talked about, you know, kind of challenges on a shift when it's, you know, when the alarm goes off, what that looks like, and we, you know, kind of painted the kind of pen picture there of what that actually does look like and the realities of that. You know, I'm just to go to that a little bit more detail, I suppose, with yourself then, and on a shift then, you know, and casting your mind back to that time in particular in the CAMS unit, what kind of things would it be? Self-harm things, would it be, are you able, and please don't, what I don't want to do is stir any kind of emotions for yourself, because I know it must be, as I get quite emotional about certain things when I recall them, obviously within confidentiality boundaries, but it's just kind of what does that look like? What is an incident, I suppose, just to drill down a bit further into that?
Yeah, absolutely. They manifest in completely different ways and carry completely different risks, whether it's to themselves or to others or even to property, really. So it may be that someone's trying to abscond.
Okay.
So it might be that someone's left the door open, or the door's not closed properly, and those young people are going to be on it. They're going to pick up on it before us. And some of these people are there under section of the Mental Health Act, so they're detained against their will. So if there's an opportunity to leave, then they will take that. And for some young people, they've got low self-esteem, so they may abscond not to get away, but to see if anyone notices, if anyone cares, if anyone's going to chase after them. So the CAMS absconsion is different to the adult absconsion, because often with young people they're running away, but they're looking over their shoulder to see if you're going to come and get them and look after them, which is really sad.
Jen, isn't it?
So it can be something like that. It can be that there's aggression towards a member of staff, and that may be because they've told the young person they can't do something or they can't have something.
So they're physically attacking, they've attacked staff.
Sometimes it's over really simple things, like a staff member's said no to them and they've been maybe a little bit more assertive in their language, and that's got the reaction that we don't want. Or it might be that this young person is psychotic, they have beliefs about that member of staff. It may be that the young person's gone through some trauma, that member of staff reminds them of somebody who's hurt them. So for all kinds of reasons we can
such a broad,
encounter.
Isn't it?
Yeah.
So an incident, I'm saying that very generically, but absolutely in CAMS especially, that could be anything.
Yeah.
It could manifest as anything.
Yeah, it may be that there are two patients fighting themselves, which is again a little bit harder to manage because you've essentially got two people involved in an incident straight away.
Wow.
It can be that the young person's having thoughts and acting on urges to harm themselves, so they may be cutting themselves, burning themselves, head banging, pulling their hair. For people with eating disorders, they may be pacing, exercising excessively. They may be trying to make themselves sick.
Jen, honestly, is that detail, I think the role of a CAMS nurse is so essential, is so vital, isn't it, to society? Because if you look at, the influences nowadays as well, so we're going back when you were doing this 2011, 2012, we look at social media now, and all of those extra pressures that weren't there as prevalent as they are now. The eating disorders you've mentioned, that must be on the rise, and that's me just looking in from a window of, just the social media, and a bit of reading on that.
It was on the rise gradually, but what we've seen is there's been a post-pandemic surge as well, so it's even more on the rise now than
people are managing,
sadly.
And all this emotional, this isolation, all of this, all the trauma of the past 3 years, isn't it? And I just think that's so desperately sad. And the reality, though, I think the point I'm trying to get across is what you do is you save these lives, because these are the crisis moments when they're, real crisis. And then the care that you are giving and the nursing intervention that you are putting in place is able then to support them to transition back home eventually, is obviously the end goal, isn't it? So on that, I suppose we've talked about the challenges. I don't want to kind of, because I'm conscious that it sounds this is the reality of it, but what would you say then, Jen, and just to kind of look at it and reflect on our whole conversation, what are some of the biggest rewards you've had from that particular area of nursing? in CAMS?
They're huge. They are absolutely huge. When
just a smile on your face when you said that as well. You can see that it is that, isn't it? It's that. So just for anyone, obviously we're not recording this on a video, but it's the emotion it provokes, isn't it? It is. And then just, Jen looks, his smile,
No, it really is. It can be really small things, like you get a little letter or a note to say thank you at the end of an admission where someone's gained more insight into their difficulties. They've now got a plan as to how they're going to manage their mental health, and that's huge to have made such a difference, particularly in CAMS at such a young age. We could be saving them from decades of severe and enduring mental illness by just helping them to get to know themselves, helping them get to know that this is something that happens to a lot of people. They're not unusual or weird. This is just something they have, and this is what we do about it. We can save them so much suffering. It's amazing. And then from the standpoint of like supporting my colleagues, I always have been that person to take people under my wing and teach them new things. Even as a newly qualified nurse, you've got stuff to bring.
You would be the mentor that I would want.
Oh,
honestly, you would. It's that I've had some lovely mentors over the years, but you honestly are up there because I just think that warmth. But again, it's not bullshit. You genuinely care. You're sincere with it, and I think your intentions are pure. If I'm honest, they are because you can see the bigger picture.
Yeah.
Of the investment of your time and compassion in that person will benefit lots of people throughout their own career.
Thank you. And when I've seen colleagues that have gone through incidents, maybe we've gone through them together, but I can see how badly affected they've been. To be able to help them through that is really, really rewarding. And also to be able to see them progress as well. Lots of people have come to me and wanted to get into nursing, and I've talked them through it and helped them with assignments and helped them by just bouncing a few ideas around for assignments and things, and seeing them come out the other side and then qualify, and being able to give them that little bit of support as a newly qualified nurse, having been there myself. It's magic. That's really, really nice.
I think that's really nice as well, what you've just, because the job is rewarding for your patients. You do get those rewards, don't you? As you say, the thank you notes. Even just sometimes when you just get through to somebody, maybe you just connect with them, finally you get that connection, don't you? And it takes, sometimes weeks, months, years it can take, but when you get that, you can't describe it. But then if that element, Jen, you just talked about your colleagues, I think that's really also important. There is a morale. I know, again, keeping this, I suppose, relative to topic in terms of the current affairs, we know that nurses are striking, we know that there is low morale because staffing levels are through the floor. They're constantly publicising about the admissions for student nurses are going down, but actually they're starting to stagnate, and I think it's really important. I think it's these honest conversations they're not having exposure to, and they need to have exposure to, because there is a reason you and I are still nurses. There are a reason that there are hundreds of thousands of nurses in this country that are still doing the job regardless of all those things, because they could quite easily, with this candidate shortage across other sectors, go and do something else. We've all said the tongue-in-cheek, I'll go to Tesco's, but actually we're not, and that's really because the reward is so great that you can't, and there is that camaraderie, isn't there, with nurses. I think you and I met each other, I think it was on a social media platform, but we instantly connected because there's that instant respect for one another of what we've probably both been through in different areas, but also the hard graft that's gone into that, and just knowing that patients are at the centre of your world, at the centre of mine. Yes, I run an agency, but I think, my core that takes us apart from everyone else is I still think of those residents and those care homes or those patients. I'm not, and I love my nurses and think about, and care about them so much, but I'm also thinking about the end, people they're supporting. So it's not, because that'll never go away for any of us, no matter which line of, which area of nursing you are. I don't think it ever goes away, and it never will.
No, and it's the families as well.
Absolutely.
In all sectors of mental health, but in CAMS in particular. Especially when they've been moved out of area, they're miles away from home, and all of a sudden over the phone I have to build a rapport with this mum and dad and help them understand that we are looking after them, even though they can't see the place, they can't can't come and visit easily. We have to build a rapport and demonstrate to them how we're keeping their child safe.
And that, I imagine, is such a tall order because, again, we're both mothers, and I think if somebody took our child and put them somewhere else, I would go into my kind of lioness mode, as I say to my kids. You go into that primal, what are you doing with my child, you know?
Yeah.
But you know it's for the best. But I imagine you have some parents that perhaps don't, and maybe they've got profound mental health, illness, and
I'm meeting them at the most stressful time.
Absolutely, and you're just taking the child off them.
Yeah.
So I think from this, in particular, this episode, I think what I have learnt about a CAMS unit and being a nurse in that environment is you have to be and understand going into it that you are going to be exposed to things that will test you. You test your emotions, test your resilience, but also I would go in actually now with that element of, I suppose, reassurance that there is going to be a team there and you work together and you've got people there that put their arms around you and you do the same when it's required.
Yeah.
And there's that quite a warmth about it. Whereas I suppose I've been, again, this is just me being totally honest, I mean, mental health is not my area, but, so for somebody who's not worked in that environment, I just think this has been so beneficial to give insight into what that day looks like, the fact that no 2 days are going to be the same.
No.
But absolutely, the reward is going to be threefold, and it's actually, you can't always measure that reward. It's going to be for your colleagues, your patients, or relatives, but also sometimes for yourself as well, knowing you dealt with something.
Yeah.
I think that's really a point as well. So honestly, Jen, I can't thank you enough for being here with me today. Honestly, I have found this, I think we could have talked for hours and hours.
Yeah,
I'm sure we probably have. But honestly, I hope everyone has enjoyed this episode. A shift in the life of a mental health nurse, specifically now a CAMS service. I know that Jen, I'm actually probably going to call her back for another episode.
We've been a bit CAMS heavy.
We
today,
have been
haven't we?
CAMS heavy, but I do think that's really important as well. Actually, it's an area that needs to be looked at. So this might be now a series of 9 episodes, TBC. But I just honestly, Jen, sincerely from the bottom of my heart, thank you so much. I think what you've brought today is just been really, really valuable in terms of anyone listening who's maybe thinking about a career in CAMS, or maybe who's just had a really awful day and a shift and thinking, oh, why am I doing it? That's normal, and it's okay to have that, and actually we all have it. And it may not be somebody who works in a CAMS unit. It may be somebody who's listening who maybe works in a nursing home, or maybe who works in a supported living service, and you've just given more insight into what that looks like, so thank you so much.
You're welcome, it's my pleasure.
Thank you so much.